Can I make a side comment about the CT scan in the ER, by the way? Our radiology community is increasingly concerned, and ER community as well, about the overuse of CTs by ER. And actually, I've just been involved with a group. They are actually pushing a totally different topic, acute appendicitis, to push ultrasound as your first step and not CT. And, again, that's a work in progress, but increasingly you're going to see ultrasound increasingly used in larger ERs. So the notion about, that they don't have ultrasound available is probably going to be changing over time because people are concerned about the use of CT in ERs.
So for several of the pages that you'll see, you're going to see data on almost identical pages. First, data based on Medicaid cases, and then so that's on page 29. And then the next page is for Blue Cross cases. And since the cost structure for Blue Cross and Medicaid cases are so different, we wanted to keep them on separate pages. So so page 29, you see this reflects the average cost per Arkansas Medicaid episode of cholecystectomy. On the left side, you see for outpatient cases, on the right for inpatient, and then further subdivided between laparoscopic and open. So for Medicaid cases, so an outpatient laparoscopic case on average, after you take out all of the kind of outliers and exclusions that we had described, on average was about $2,100. Okay, so that's the professional component, that's the outpatient facility, it's the pharmacy component as well. With the little bit of inpatient that you see in there, that's based on the readmission. Okay, so that was an outpatient laparoscopic procedure, but at some frequency there was a readmission. And then just to compare that to at the far right end, you have an inpatient open case averaging $5,100. So I think the cost differential there is probably not surprising to folks, but we also anticipate that this may be information that general surgeons and their office staff may not have seen before in this manner. The next page, page 30, has similar information for Blue Cross. You can see, similar breakdown in costs. And if folks have kind of further questions about Blue Cross, I know that Matt could answer those questions. The page 31 is for Medicaid, and then page 32 is a similar analysis for Blue Cross. And so this is Dr. Golden had shared the kind of generic distribution chart earlier. This is specific to cholecystectomy. So each one of the columns that you see, each one of the bars on here is one of those 122 primary surgeons who performed a Medicaid cholecystectomy procedure in 2010. That was not subject to one of the outlier or clinical exclusions that we described. The dark bar are those surgeons who had at least 5 Medicaid cases within that period, and the light bar are those with fewer than 5 cases. Okay, so there really are 68 surgeons who had at least 5 Medicaid episodes. And you'll see so this is the average cost, and this is for each one of these surgeons, it's a blend of some inpatient, some outpatient, mostly laparoscopic procedures, some frequency of open procedures. And you see a pretty significant cost variation, really 2 to 3-fold cost variation, 2-fold cost variation in the average cost between those at the kind of the right side versus even some with moderate volume that are over towards the left side. And you might anticipate a lot of that cost variation is actually being driven by differences in the frequency of open versus lap, as well as the frequency of inpatient versus outpatient procedure. Page 32 is similar information for Blue Cross, scaled relative to in this case, this chart, it was scaled relative to the highest cost provider, just to show the relativity. Just go through a couple more charts here and then give folks opportunity for questions or comment. Page 33 and 34. Page 33 takes all of the Medicaid cases and just arrays it based on the number of episodes per surgeon. So we had said before that each of the payers intends to apply a standard that a general surgeon would only be rewarded with gain sharing or subject to risk sharing if they had at least 5 cases. So for Medicaid, that basically 86% of the cholecystectomies for Medicaid are performed by a surgeon who had at least 5 Medicaid cases in a year. If on the next page, if you looked at Blue Cross, it's 94% of the cases. So, we feel good that even if we exclude those surgeons who have, statistically too few cases, we're not kind of letting too much water under the bridge, so to speak, and we can really focus the incentive system on the folks with meaningful volume. So page 35, this is, again, for Medicaid. So you see from left to right that were performed, that were open. And so just focus on the darker blue bars. These are the surgeons with at least 5 Medicaid cases in a 12-month period. So, not surprisingly, kind of the majority of those surgeons had less than 10% of their cholecystectomies were performed on an open basis. The average for Medicaid was 5%. However, we do see some number of surgeons who had between 10 and 30%. We had a few that were north of 30% of their procedures were done open. Page 36, similar analysis, same analysis done for Blue Cross. Overall, we saw a lower frequency of open procedures, so only 1.5% on average, but still some meaningful number that, despite the overall average being 1.5%, we saw 9 surgeons who had at least 11% open frequency. So this is, by the way, this is not to we present this data more. It probably introduces more questions than answers about why would some surgeons have 2, 3, 5, 10 times the frequency of open procedures of other surgeons within the state, but it raises some questions. Page 37 and 38 is a similar analysis, but for the frequency of cholecystectomies that are done on an inpatient basis. So page 37 is for Medicaid, page 38 for Blue Cross. The overall inpatient frequency for Medicaid, on average 26%, but some number of surgeons who are above 50% of their cases are done on an inpatient basis. For Blue Cross on page 38, the overall average 12%. Now, I think that we have not, tell me, Julian and Matt, the ED adjustments for patients presenting with chest pain in the ED, we haven't made those adjustments yet. Is that right? Right. So, we do allow for there is the possibility, even a likelihood, that some number of those surgeons who have a higher frequency of inpatient, they may be almost entirely taking their cases through the ED, and so they may, just based on time of day or other factors, they may be more likely to have an inpatient admission. So we allow for that as one possible explanation.
This is Fayetteville. It might be that if you're at a chest pain center, that these people are just coming through the ER.
I'm sorry, I'm not sure if I picked up your comment. You said that if you're near a testing center, then people may be a chest pain center, then people may be all coming through the ER. Yep. And so once we apply that exclusion for ED admissions presenting with chest pain, that would clean that up. Is that right?
It seems to me a lot of your outliers are the physicians that are doing less than 5 gallbladders a year.
I think that's right. I think certainly on the cost distribution chart, we saw that the extreme outliers at the far left of the chart are folks, with small volume. However, even among those with at least 5 cases per year, we do see really a 2x range in overall costs, and we do see some examples on the order of kind of 10, 15 surgeons who have a moderate number of cases who still have a high frequency of inpatient admissions, abnormally high frequency, and I think we need to kind of look into. I'm sorry, go ahead. I think you have a comment.
Hello?
Yes.
Is there going to be some sort of education provided to the consumers of Medicaid and Blue Cross Blue Shield that they're going to have a change of expectations in the rapidness that they're going to be treated, meaning that if they show up in the ER and they have a bad case of biliary colic, we're going to tell them to suck it up and go home, and we're going to do it as an outpatient? Are you going to educate them that?
Well, the goal is to leave the clinical decisions to the judgment of the treating provider. So, I think that they would only be. I think that would only be the consequence for the patients if the treating provider thought that was dictated. And again, I'll remind you that at least based on using the first wave of episodes for other conditions and procedures, just as an example, the proportion of providers who ended up kind of even starting out in that red zone was relatively small. It was on the order of about 15% of providers started out in that red zone. And actually, the episodes are designed so that if everybody kind of moves down towards kind of an average performance, that would be success, right? And so, as we just kind of consider, how extraordinary a pressure could this incentive kind of create, it's important to recognize that at least historically, a lot more providers were kind of put in the green than in the red. And at the end of the day, it's still entirely up to the judgment of the treating provider whether they feel that it would be appropriate to send that patient home without surgery or to go ahead and perform surgery.
In the perinatal side and the respiratory, it was not just Medicare and Medicaid would kick patients out as dual providers. So are you saying only for this episode of care, if they have a dual eligibility, it has to be Medicare and Medicaid to exclude them? Or if they're, say, a Medicare with a Blue Cross secondary, are they excluded?
So the way to exclusion on this one is that because when we build the episode based on the claims data, we need a complete history of their medical history and the claim history. So if there's a dual eligibility, given that only Medicaid is in, Medicare is not part of the claims database here. If they had dual eligibility or they had third-party coverage, then we exclude that patient from eligible for episode payment.
So if they have any dual coverage, like they're, say me, I'm a Blue Cross and a core source because my husband has me covered and I have coverage, then I'm excluded.
Right, exactly.
Okay,
and
so we have a lot of Medicaid
the same will be true
patients.
for Arkansas Blue Cross.
Okay, so we have Medicaid patients that are Medicaid and Blue Cross, like my son, because he has Tefra. So he would be excluded. Or say we have a Blue Cross patient that's on a limited income and for some reason they get a Medicaid spend down. And that's where I go back to
the intent is that we only want to include cases if we are able to reflect their full claims history. So if we had a patient who had eligibility for coverage under two different types, where one was providing coverage for medical services, another was providing entirely unrelated coverage, for example, for developmental disabilities, and if that could be kept entirely separate, then I would anticipate that Blue Cross could probably still analyze the medical claims costs for that patient. But if the dual coverage is kind of splitting coverage that should be considered as part of the episode, then those patients should be excluded.
Okay, and my other question.
We'll be able to. I think we'll be able to refine that going forward and be able to be more inclusive. But for the purpose of being a little bit more conservative on this, we're starting from that perspective.
Okay, my other question is related to the diagnosis codes in like your spec manual. So you've got a list of cancers, you've got a list of COPD, some of your risk modifiers, your outliers. It might help some of the physicians. So similar to the perinatal where you had all the codes out there for the diagnoses like amniotic fluid embolism and those things that would kick those patients out of those populations. Is there going to be a list of diagnosis codes, for instance, the chest pain, that might help the physicians, or the physician that was discussing the issue with the common bile duct stone, where they might not have done an ERCP that was billed. For instance, I can see where you may have a cost outlay for where we're a rural facility and we get the patient initially, but then we have them in the emergency room. We may have done the ultrasound, but we have to transfer them because we don't have ERCP capability. So we transfer them to another facility for surgery, so you're going to have added cost.
This is a mid-course presentation. We have not come up with the final documentation. When the final episode is created, those details that you're talking about, like on the other episodes, will be put out on the web.
Okay, so we're still building here. And then
Yeah.
going back towards the back, when you were asking about ideas about your physicians with your higher rate of inpatient and also open,
Yes.
I'm thinking along the lines of your rural providers as well. And the physician that was talking about where he's got to decide on the anatomy or not and what he's got available for him at the point in time that he's doing his procedure. That may be
Right.
where you're seeing that conversion of inpatient and open. And that's all we have here, unless you have anything else.
That's very helpful.
That's all we have.
Thank you.